Top Med Talk.
Well, hello and welcome to Top Med Talk. I'm Desiree, Chappell, your host, and I'm joined by Monty Mythen, my co-host. Hello, Monty.
Hey, Desiree, it's good to be here
It
in
is.
my new role.
You are in a new Monty. For everyone who may not have heard, what is that new role?
So I'm now the Senior Vice President of Medical Affairs for Edwards Life Sciences, the critical care component of it. Great honor and privilege to take over in that position. I'm still an emeritus professor of anaesthesia and critical care at University College London, so still have my academic activities as well. But having spent a sabbatical with Edwards, I've gone over to the other side, and now I'm very proud to be in that role in one of our industry partners on Top Med Talk. But that means I've stepped down for a number of roles.
You have.
Yeah.
You did a lot of stepping down, a lot of goodbyes this summer.
My knees are sore from
stepping down
doing
so much.
so much stepping down. I'd like to sit down for a while. So.
Well, I think you did better put some roller skates on. You're not going anywhere. I think you're going to be busier than ever. Well, I know you have stepped down from the co-editor-in-chief position here at Top Med Talk, but still very involved.
Yeah, so we're looking for a new co-editor-in-chief.
We've
got a strong shortlist so far.
We do, but if anybody out there is interested, let us know. Well, Monty, we're here in Nashville, Tennessee, close to home, close to Louisville for me, ahead of the American Society for Enhanced Recovery, ACER, which both of us have been a part of that wonderful organization in the past, and excited to hear what happens this year at their meeting.
Well, our good friend, regular contributor in the past to Top Med Talk, Matt McAvoy, is the current president of ACER, so that's why it's here in his hometown. Yeah,
at Vanderbilt. Yeah. Well, while we're here in town, we have had the opportunity to catch up with a friend from the ERAS Cardiac Society and a previous guest here on Top Med Talk, Dr. Seenu Reddy.
It's so great to be here with you. I'm glad you all are here in Music City, USA.
That's right. Your hometown here. It's a lot of fun. We saw and heard some of the fun last night.
Good.
Briefly, we should add.
It was actually very brief. Got it kind of late last night. Well, Seenu, for our listeners, tell us a little bit more about yourself and your practice here, and then maybe we can dive into a little bit more about ERAS Cardiac.
Yeah, I currently serving as the chief of cardiac surgery at TriStar Centennial Medical Center, part of the HCA system. And I also serve as a national medical director for them, one of 4 heart surgeons that helps really their quality initiatives nationwide. In addition to all of that, I've, as you know, been very involved with ERAS Cardiac and have been on their executive board for a number of years, along with Dan Engelman and several other great people. But I'm really thrilled that we have really been able to have the society not just grow, but really have major impacts, I think. It's so exciting whenever we have our meetings, and we've really become a part of all of the major cardiac surgical and anesthesia conferences. They've recognized the importance of ERAS and have included us either as a module, given as a reserved portion of the meeting.
Yeah, you guys are everywhere, it seems like, which is fantastic. Well, again, for the listeners that may not be familiar with that society, I think people have heard of ERAS Society, maybe ACER. So what's different about the ERAS Cardiac Society, and why did you guys kind of decide to go on your own path?
Yeah, I think, we do still obviously operate under an umbrella of the enhanced recovery societies as they exist. But what we recognize is that cardiac surgery, particularly, had a lot of opportunities to benefit from ERAS, but some of the benefits and the issues and the concerns in the cardiac surgical postoperative pathways are very unique to cardiac surgery. For example, just the nature of the approaches to the heart, meaning the sternotomy, has many areas that both can inhibit patients' recovery, but have opportunities for enhancement. Along with that, there's quite a bit of hemodynamic perturbation that goes on during both the acute and the post-acute phases of cardiac surgery that may be more unique to our patient subsets than some others that are going either more minor procedures or abdominal procedures. So we recognize that the pathway of care is quite unique, and that led to us developing the Enhanced Cardiac Surgical Recovery Society.
And we've done a number of interviews since the beginning of Cardiac ERAS. If folks want to listen to some of those and the history and the whole journey. And as we've spoken about it in the past, we had a little bit of sort of joking with each other to say that when we look at the guidelines, as you were just referring to, most of the list looks the same as is done elsewhere, with those key variations you've just been referring to for cardiac. But when it comes to what success looks like, we relatively recently did a sort of historical piece of going back to our interviews with Henrik Kellett about what good looks like. And we still came to the conclusion that good looks like patients who can eat and drink and ambulate and have got the tubes and the drips and the drains out, as opposed to the alternative, which is not so good. Is that still the big message,
Absolutely. I think, that some people summarize it as dream. It's a lot of us do with the earlier initiation of diets, the reduction in the fasting period before surgery, enhanced educational opportunities, really getting the patients engaged in what to expect with their surgical journey, the mobility, early mobilization. And then finally, the part that I think is universal, that's been recognized in medicine in general, particularly in the surgical specialties, is the reduction of opioids and the administration of opioids, the duration of opioids, the intensity of opioids, and even many people have been able now to successfully conduct major operations opioid-free, which is really remarkable.
Mm-hmm. Yeah.
So, and the other success markers, which we all recognize in the world of surgical intensive care, but particularly in cardiothoracic intensive care, is early extubation.
Yes.
Which seems to be a key contributor. And then early discharge from the ICU because things are fixed, not rushed discharge from the intensive care unit. But that's a real win-win. It opens up the pathways, it allows the flow of patients, and it usually equals success.
It does. I think one important distinction we make, and Dan Engelman particularly makes, because his father was one of the authors back in the 80s, there was a concept of fast-track cardiac surgery. And we really want to make sure we're differentiating that ERAS cardiac surgical care is not fast-track care. It may be a side benefit, as you point out. It may, and oftentimes does, equate to earlier discharge from an ICU, but it's not necessarily the fastest discharge from the hospital.
Yeah.
What it means is a more functional disposition when the patient leaves, whether to home, to rehab, to a skilled facility. It's that they're leaving the hospital in a more functional state, so their ongoing recovery has been enhanced, so to speak.
Yeah. Oh, and almost getting them to a higher level of functioning.
That's right.
From where they were before, especially if you do get into that prehab space, which I always think is interesting.
Well, I think that was where I was going to, is that the other big thing we recognize, and already kind of segueing to what are the opportunities left within enhanced recovery. Number one is for sure prehabilitation. Mm-hmm. I think the concept of getting people physiologically ready for surgery.
And we're not just talking about like exercise, right? It's like nutrition, mental health, and well-being, right?
Social support structures, and obviously the elimination of alcohol and tobacco use cessation, really spending time on that. In the patients I've done that, it's been remarkable. You going back to early extubation, really sailing through from a pulmonary standpoint when just a 2-week cessation from tobacco.
Oh, wow.
Which we didn't used to do, unbelievably.
A couple more things on that. I remember the 20 plus years ago, don't mean to ruin to Dan Engelman's father here, but the fast track at that stage from team anesthesia back in the UK was, can we extubate on the table?
Yeah.
Yes.
Which from the intensive care end of things seemed a bit odd, because now they brought us around a patient in a heap.
A poor state.
And shivering cold.
And you've bought the bed.
Messy.
Exactly.
So it's not as though you're not buying the bed. So please bring them round asleep and we'll just wake them up quickly.
That's what our unit nurses tell us, and our respiratory therapists and our intensivists. There's still a fascination with it for some reason. I don't know if it's just this hurrah moment, we did it, but I agree with you 100%.
I've talked to a lot of, I know, I've talked to so many cardiac anesthesiologists.
6 to 8 hours seems to be the key.
Absolutely, yeah.
That's the window.
I've talked to so many cardiac anesthesiologists and CRNAs and teams where it's like, they're like, oh, we extubated on the table. I'm like, why? Like, I mean, I just think it can increase OR time. And, you get somebody over, you have them, lightly sedated. They just start waking, kind of starting to wake up a little bit, but everything's calm, cool, calm, and collected whenever you drop them off.
Certainly.
It's not always like that when you extubate.
Well, there's a couple of issues, right? There's the temperature issue. I mean, hypothermia and normothermia, and reaching that is a lot easier on a ventilated and sedated patient. Bleeding.
Yeah.
Which
you can't make any sense of the hemodynamics.
The hemodynamics are all over the place.
You just haven't got a clue.
Yeah, it does. Well, so we've talked about, some of the indicators that, of success, specifically within the cardiac space of early extubation time, reduction in ICU bed hours, because that all is, super important in this space. So this is something that you and your team actually looked at, and now you have a paper and publication.
Yes, I think, we recognized that early on, one of the things that we could make a big impact on, and we wanted to kind of test it in the real world, looking at 3 different institutions of different sizes. And we didn't get too much in the nitty gritty of how do you have to manage the hemodynamics. What we just said is that there's a goal hemodynamic parameter we want people to stay within, and we let people be more real world about how they did it. And we're looking at ways to see, did this make an improvement in some of the endpoints or measures of success, whether it's kidney injury, ventilation time, and just ICU time.
Okay.
And I've seen the paper in it through its journey, but now it's available. It's published now in the JTCVS. What's the JTCVS?
Well, it's actually one of our more prestigious journals. There are 2 major journals in cardiothoracic surgery. One is the Annals of Thoracic Surgery, and it's supported by the Society of Thoracic Surgeons. The JTCVS that Monty refers to is the Journal of Thoracic and Cardiovascular Surgery, and that one is affiliated and supported by the older society, which is the American Association of Thoracic Surgery, the AATS.
Okay, and the paper's open access.
So it is, so you don't have to pay, you don't have to be a subscriber, which actually gives it to so many more people.
It really opens it up.
The journal is really part of the, like I said, the AATS, so typically members and those subscribers. But with this paper, we have made it available to a broader audience.
And first author, Seenu, Reddy, just to read the title, because I'm cheating here because I've got it in front of me. Advanced Artificial Intelligence Guided Hemodynamic Management within Cardiac Enhanced Recovery After Surgery Pathways, a multi-institutional review. So why don't we take that backwards, Desiree? The multi-institutions, you said it was real world.
Yeah, Swedish, and then St. Francis.
Out of Seattle, Swedish out of Seattle.
That's right. And
Indianapolis.
Okay. Both great institutions led by really extraordinary teams, surgical and anesthesia. We were both involved with the paper, the data, as well as, so it was a true effort. It took a lot, because tell you one of the things in today's world is data sharing.
Oh my gosh.
To get the data sharing between those 3 institutions and our sponsor with Edwards was a big hurdle, but we were able to make it happen. Yeah. And I have to mention, I mean, I think a lot of people look at this in different ways, but I think it's so important to understand industry support can be very critical and valuable without adding necessarily any bias or commercial influence, but really giving the kind of the glue to help the 3 of us come together to do this.
Well, and I think one point to make, and this is from my own personal experience, that when you're not academic sites, this is, it sounds rather community-based, real world. It's, there aren't the resources there. And so when you can get help to actually work with the data and be able to get access to some of the things that you normally wouldn't have, that's where that really comes into play.
You mentioned the Edwards sponsorship, and you've been through it, had a similar experience with this, with publications recently, Desiree. Edwards' contribution was to support what they called an honest broker, which is a term I initially didn't like, because that implied the fact all the rest of us were dishonest. But how did that work, Seenu?
I think first of all, Edwards provides invaluable educational support to the nursing teams. Remember, this paper took place during a really challenging period for healthcare in the United States.
It was
during the pandemic. During the pandemic. And we were under a lot of stress with our nursing teams and so forth. That may be a separate paper analysis we can do, because we'll get to the meat of it. But in terms of, there was a lot of nursing turnover. There was a lot of opportunity for variability of care, especially with traveling nurses and so forth. But so going back to Monty's question, the support was there, number one, to educate the teams on how properly to use this AI-guided software and data collection and management system. And then number 2, they were really instrumental in helping all of the data get shared and gathered. That's how it worked.
And that was a third party that's mentioned in the paper. They said the 3 centers, I understand it, sent their data to the third party.
That's right. So it's really free of any bias or adverse influence. Yep.
Yeah. Agreed.
So you might as well get to the
heart of the matter.
Let's talk about the design here. So you had the data from 3 different sites. How many patients did you actually end up having for this?
Monty, you have the exact number.
1404.
We had over, and of those, over 1,100 of really what I'd call core data set. And all institutions contributed substantially to it. So it wasn't like one institution had the bulk of the patients. There were obviously variations, but we had it where we could really have meaningful numbers collected from each of the centers. And the way that worked is we wanted to choose centers that were reasonably busy, did already good quality work. We weren't trying to have large disparities in the quality of the outcomes in terms of their surgical outcomes. And then we also wanted to have centers that had experience with the technology. And then finally, we wanted to talk about patients that fell into a reasonable category, like a coronary artery bypass, not looking at rare procedures like dissection patients or something like that.
And so we're looking at the infographic here, which is really nice.
Yeah, it makes it so nice to have a quick dashboard.
It does. We'll put a link to that on the show notes. Seenu, so this was for ERAS cardiac patients. So all the patients were ERAS patients. Is that correct or no?
Yeah, they were in some sort of ERAS pathway.
So they were in some sort of ERAS pathway. The difference between the two different groups was whether or not they used the Acumen HPI AI technology to drive hemodynamic management.
Precisely.
And is that, and talk to, so one of the first questions
that I had. Cohort. So that is because we had it already implemented. So we didn't want to take away the ability to use it from a set of patients, right? That's when it gets into some of the ethical dilemmas. If you feel like you're giving a therapy or a treatment that works and is doing good for the patient, you don't want to create two groups now that one patient. So that's why the reason for the historical control.
Okay. And then when was the use of HPI integrated? It was it within the continuum of care.
In almost all institutions, it's implemented, and that's another unique thing about cardiac surgery. We're talking about what's the difference between general cardiac surgery. Because our patients are on cardiopulmonary bypass, we find the use of this type of data collection and utilization really the most useful on the arrival to the ICU.
Okay.
Because intraoperatively, you have other modalities that are typically being used. Number one, you have TE in almost every patient because that's become standard of care. Number two, the volume infusions are very different because through the cardiopulmonary bypass circuit, as we're coming off, I can give 100 cc's of fluid in 30 seconds or less.
Yeah. So we've talked to a lot of, I've talked to a lot of cardiac teams. They do use, so you can use the system, the HPI, in Hemisphere and Acumen.
Even preoperatively.
Yes, preoperatively, intraoperatively, and a lot of people do see value of in other ways there. But specifically for this, you were looking at cases where they had to be using the software within an ICU.
On the level of ICU. That's right.
All right, because that was one thing I just want to make sure.
Now, your hypothesis was, and as I said, I traveled part of this journey with you from the point of view of reviewing some of the preprints and giving a little bit of advice, which may or may not have been helpful.
Very helpful.
Was that you'd get a shorter vent time and a knock-on effect would be a shorter ICU time. Why did you all think that better hemodynamics would help people get off ventilators more quickly?
Well, I think we base it on data that's already been published out there, that we can see that the more purposeful and intentional administration of fluids, at the end of the day, that's what's going on with a lot of these patients for their hemodynamic management, is either the appropriate use of fluids or pressors results in a better milieu for the patient to now stabilize and then get on to the extubation pathway. So one of the things that can delay extubation is hemodynamic instability, because you're not going to extubate a patient in the midst of hemodynamic instability. Number two, the other thing that can delay patient extubation is massive transfusion of volume, whether it's colloid or crystalloid. And we all know about kind of the wet lung syndrome or the overloaded patient. So I think the avoidance of both of those things and the more rapid attainment of a steady state, especially with the HPI component, knowing that you have the opportunity to be experiencing hypotension, and then by avoiding it, you're reaching a steady state sooner, thereby making a patient more suitable for extubation.
Well, and I can imagine, I haven't used this technology in the context of an ICU setting, but I've, worked there for a while before I became a nurse anesthetist. Understanding now and working with cardiac patients, there is so much variability in where they are on their fluid status. They're on bypass, and traditionally, and we've talked about this before, hemoconcentrating them, drying them out pretty significantly to get their crits down when they come off.
Right.
There's been a trend towards that, and they're really dry. And then, as we as team anesthesists trying to figure out before we actually take them to ICU, and then we get there and there still seems to be a lot of variability, and you don't really know where you are unless you have kind of the advanced technology. It's really hard to go off blood pressure alone, or any other indicators. So
So your headline result was a reduction in ventilator time.
Yeah,
that's right. Absolutely.
Statistically significant
across institutions.
Yeah. So it looks like here, if we looked at pre-program control with almost 800 patients on the ERAS pathway, and then with the intervention, which was 609 patients with HPI and ERAS pathway. Total event time was 13 hours with the ERAS or the normal pre-program control, and then reduced down to almost 8.5 hours.
Yeah, and I think that's
significant.
a meaningful amount of time, because I tell you that you see any ventilated patient and the first thing they do is point to their tube and they want it out. I saw one on this morning.
Yeah.
I made rounds at 6 a.m. this morning.
There's also a reduction in ICU length of stay, and there's a reduction in stage 3 AKI, the worst form of AKI. Now, I know when people will look at that, they will say, well, the p-value for that is 0.25, so it's not statistically significant. But I understand why they allowed you to have it in the paper and put it in the infographic, because that's the worst form of acute kidney injury.
That's right.
And it went down by 40%, almost half.
Almost half.
Yeah. So it's in there to say it's way underpowered to know if that's real or not, but that's kind of worth pursuing. I wanted to go through that. Sorry, do you want to comment on that?
I think it makes intuitive sense. I think you're exactly right. I think the power and the ability to show it, because the rates of AKI are already been reduced because of many of the ERAS pathways already try to mitigate one of these really most dreaded complications, which is AKI. Yeah. But as Monty points out, the severe form of AKI, if we can really make an impact there, that makes a tremendous impact, not only for the patient's hospital stay, but it's actually a lifetime impact.
Yes.
So there have been many studies that show higher rates of death, premature death with that.
Yeah.
I want to take us forward to the figures at the end.
Yes.
So they're the most dramatic figures.
It is.
Absolutely.
The data is presented as box and whisker plots.
Scatter plots,
The median interquartile range, the outliers. And then the extreme outliers are presented as individual dots. And I can see why Desiree's looking at it and saying, wow.
Yeah.
Because when you see it visually, I mean, the heart sink in cardiac ICU, apart from the saddest possible outcomes, is if the patient's still on the vent day 2, day 3.
Yeah.
Absolutely. Yeah.
And if the patient's still on the unit day 5, day 7, week 2, week 3, that's when we're getting, very disappointing for everyone concerned. And when you please go and look at the figures, well, describe them, Seenu. What are we seeing there?
I think the number one thing you can see is what I would call kind of a compression to the mean or a reduction in the variability. The scatter, as Monty points out, I think anybody, wherever you are in your data interpretive skills, can just visually look at this and say, wow, there seems to be a reduction in variability.
Yeah.
And I want to go back to something I said very early in our discussion today about the era in which this was all done. Mm-hmm. This study was done in a time when there was a tremendous amount of nursing turnover and a tremendous amount of nursing variability.
Yes.
So in that milieu of high variability in most of these ICUs at these 3 centers, we still were able to show, versus a historical matching cohort during which there was very little variability in nursing turnover. That was maybe one of the most stable times of nursing we've had, was before we went into the pandemic, that we still achieved a tremendous reduction in the care of the patient in terms of where they were with extubation pathways and in time of mean blood pressure and so forth.
It's just so fascinating. I mean, to see this again, hopefully we can get this into the notes where people can take a look. We talk a lot about reducing variability and leading, standardizing practices. And just remind us again, this is something that was not was it a strict protocol that people were following, or is it kind of just implementing acumen into their own process at wherever they are?
So yes, there's a protocol in the sense of each institution had their protocol, and that we were fairly standardized on when we'd extubate a patient. What we didn't delineate was how much fluid you have to give with we didn't say everyone must give 250 cc's. If your unit was used to giving 500 cc boluses, then continue with that. If you used norepinephrine versus phenylephrine for the pressor, we didn't get into that.
Gotcha.
That was too much of a dictum to put out to all of these different institutions that practiced really high quality care anyway.
Yeah.
Similarly, we didn't specify, you had to have a NIF of 25 versus 20 to extubate. We didn't want to get into that level of weeds. What we said is, follow your protocols, and the protocols, the other beauty is that they weren't different from pre and post. It just shows that what happens when you can change. That's why I really wanted to show the effect of this variable on those outcomes.
Yeah, fascinating. Monty,
I was going to say, wearing my old Professor hat. Let's go back 10 years ago. I'd be there saying, lots of reasons I don't believe this. Is it an epiphenomenon? Is it cause and effect? If I then jump forward to when I was sort of wearing my hat, healthcare improvements and trying to, show me the money, C-suite type of stuff. I'd say, well, I don't care if it's an epiphenomenon.
Whatever it is.
things got a lot better. Have you carried on doing it, Seenu?
Absolutely. Yeah, it's standard of care in our unit. And what I've found is the ongoing benefit for nurses. What we find is actually and this may be, again, another paper idea we're generating, is that the newer nurses that are coming out today seem to really pick up the ability to use Acumen and then like it and embrace it even more than kind of our older cohort of nurses.
Which is so interesting, because I've always felt, as I've embraced technology and really worked with it, if it goes along with kind of what I'm thinking, and I can validate it, then I'm like, oh, I love this. This is great. Not everybody feels like that, but I think the new generation, their phones. They're used to tech. They're just used to technology, and I think they're used and want to embrace it. So, to Monty's point, the C-suite's really interested in this. Maybe the event times definitely interesting, but the length of ICU time, you're able to cut that down.
Yeah, because I don't think, and it's not all related just to the vent time, right? So you're achieving a more steady state of hemodynamic status to allow the patient to go ahead and transition to a step down unit.
Yeah.
So yes.
Yeah. That's fascinating.
Do you see many readmissions these days, Seenu? If you get your patients,
it's much more infrequent than it used to be. I think a couple of reasons. One is we're more purposeful in the way when we do transition out of the ICU to the regular force. So usually it's an event-driven readmission, some sudden respiratory event. Typically not for hemodynamics. Occasionally a rhythm event. They go into such AFib, we can't control it or become severely hypotensive due to that. So the rhythm and those things. The other thing that I'd really be interested in seeing, and we were talking about ERAS and what does maybe 2.0 look like. Another big area of interest is delirium.
Yes.
And is there a opportunity for delirium reduction, both pre-operatively in terms of maybe doing what I'd call a delirium check sheet or assessment? Are you on medications that may create more delirium in the post-operative setting? Because we have already reduced opioids. We've gotten pretty light with our benzos. So then does something like this also help with delirium by maintaining appropriate hemodynamics, appropriate mean arterial pressure, less fluids or appropriate fluids? Again, we're not saying that give less fluids or to use more pressors or give less pressors and more fluids. We're just saying give the appropriate amount.
Yeah. I think that's something good to chase too. When we're talking about things that affect the patient, that's a real patient experience. AKI or having, hemodynamic instability, if it's not as bad, it's harder for patients and families to kind of understand that. That's all very abstract. But when you see your family member experiencing post-op cognitive dysfunction and delirium, that's bad. That's
very stressful to the family.
It is very stressful. So I think that's
them. Their number one question is this the way my loved ones will be the rest of their life?
Yeah. So I think that's something good to look at in the future. Monty, any closing questions or comments?
As people talk about real world evidence, and, its veracity and the science behind it, I always look at these types of papers and say, what this says is it worked for y'all. If someone else wants to give it a go, they need to determine if it works for them. You see, it doesn't. It's not like you've proven a drug cures cancer. It's basically saying you can.
But I think it's so important for us to share the real world experience, especially out of the context of normal academia, which is great. But I want to know how it's going to work for me every day with production pressures and and private-ish type practice.
I think you're really hitting on something that's so important, is that all of us have skeptically looked at papers that come out of some of our key institutions.
And finest institutions in there.
Well, they make it work. And of course, they can make it work with all their resources. So I'm going to teach you all a Southern pluralism. So Monty said, y'all made it work. But then I'm saying all y'all made it work.
All y'all.
Which was three institutions made it work. So at very different parts of the country. You had a Midwestern, a Southeastern, and then a Pacific Northwest institutions. And it's always fascinating to me when I look at medical publications, how, anywhere you go in the United States, if you go to a fast food restaurant and you order their signature food item, it tastes the same, right?
Yeah.
Whether you buy it
a Big Mac's
in New York City or on the West Coast. But the care of a STEMI or a ACS or a heart attack patient in New York City versus in Miami versus in Seattle has been shown to be very different. The rates of PCI performed, the likelihood of being discharged on certain drugs and so forth. So I'm hoping, this show that we could all do it in a different part of the country.
And collaborate.
Yes, which is really important. Seenu, thank you so much for joining us today and coming back on the podcast. Hey, if people are interested in finding out more information about the work that you are doing or the ERAS cardiac team, what's the best way to get in touch with all y'all?
The ERAS cardiac, of course, we have a website, erascardiac.org. You can find us there, and we're open access. We really try to make it where our algorithms, our protocols, and our publications are all available through links on the website.
Good. And then hopefully either later this year or early next year, some new guidance coming out, right?
Yes.
2.0
part of the inherent kind of mantra of enhanced recovery is continuous quality improvement.
Yes.
And so at the center of that, we're always trying to push the envelope. So I think be on the lookout for ERAS 2.0.
That's awesome. Seenu, I know you're on call. Thank you so much for sitting down and taking this time. I'm sure your phone's blown up over there. But hopefully we'll see you soon. And congratulations on your work. This is fantastic.
And thanks to both of you. And again, shout out to Monty and Edwards and all of my collaborators on the papers, Dr. Gerdish and so forth.
Yes, it was a great team
effort.
Yeah. And thank you for listening to Top Med Talk. You can always find us on your favorite podcatcher. We're on the social media platforms, all of them, Twitter, LinkedIn, Facebook, Instagram. I think we have a page.
X.
Oh gosh, I'm so sorry. Yes.
We're not on Twitter anymore.
He wants to get rid of all the birds. That's what his famous phrase.
That's right. Yes, not on Twitter. Sorry, not on Twitter. X. That's going to be a hard change there. And at topmedtalk.com. We're working on a new website. So if you find
that soon.
Yes, that's going to be coming out soon. But if you find our website's a little shaky, that's it. We're doing some revamping there that will continue to have all of our great content. And coming up, Monty, one of the favorite meetings of the year.
We're back in Dingle, Ireland.
Yes.
Our longest standing evidence-based perioperative medicine, my last in my, step down role as
one of the last step downs.
Last big step downs. But we're having the first in a series of meetings about the value proposition of perioperative care. So there's a global think tank gathering from as far away as Australia, USA, to discuss how we try and more effectively present these value propositions to our C-suites effectively. To say, these clearly are good for patients, these endeavors, and they're good for everybody. How do we communicate that more effectively? Well,
and I'm super excited about that. But a big plug for Dingle. I know people ask me all the time, I want to go. Well, you can go.
We're trying to get Seenu there.
I know. One of these days. But if
a friend of mine bought a castle there, I can stay.
You have somewhere to stay. It's going to be great. But you too could come to Dingle. So check it out on the EdPom website. Might be a little bit late for this year, but if you're planning some vacation for 2024, take a week off and come to Dingle and learn with us. It's a fantastic meeting. And the ASA is coming up this fall, October.
San Francisco.
14th, 15th, 16th in San Francisco. We are going to be live there. We have a beautiful booth supported by the ASA and all of our wonderful sponsors. And that's going to be really exciting. We're going to be doing our podcast from there. If you're around the exhibit hall, come and please say hi. We always love to hear from you. And, we hopefully can sit down and have a little chat. So,
and maybe you'll get to meet the new editor-in-chief.
Maybe. Who is that? When we figure that out. All right. Thanks so much for listening. Have a great day. Cheers.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EdPom, evidence-based perioperative medicine. We'd love you to find out more about that. If you check out edpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out edpom.org now.